Annually, there are about 250,000 pediatric burns. And then here at Children's, we get about 2,000 visits a year. So a lot of them are in the emergency room, but a lot also, some are admitted to surgical care. And then we also see a lot of patients that never hit our emergency room or inpatient admissions that are seen at outside hospitals, pediatricians, urgent cares, and then referred to us. So lots of different capacities. Who comes to Children's for a burn? Do we see every pediatric burn? No, but we do see a lot. So this is a list of referral criteria. One of the things that, excuse me, that directs a lot to Children's versus an adult provider or an adult institution is just one of the criteria is a pediatric burn. So whereas an adult provider, an adult hospital may feel more comfortable with it, a lot of outside hospitals refer to children. So we definitely should see anyone greater than 10%, any concern for full thickness injury, burns of certain areas, hands, joints, face, genitalia, feet. If we're worried about child abuse, which is always something that we do have to consider, also child neglect, patients with other comorbidities, and then hospitals that may not have pediatric providers. Mechanisms. So this is a list of common mechanisms. Scald and contact burns are by far our most frequent here at Children's, but we can also see flame burns, chemical injuries, as well as electrical injuries. So how hot is too hot? This chart shows some various temperatures that we may see related to a burn injury. So serious burns can happen within 1 second at 155 degrees. So 155 degrees is well below frying, baking, stovetop, crock pot, boiling water. Safe bath water is 100. And then it's recommended that household water, hot water heaters are set at 120. Burns happen fast. That's an important thing for families and for providers, for everyone to remember. It only takes a second for an injury to happen. So I mentioned common causes. Scalds are one of our most frequent. We see soup, tea, coffee, hot water, baths, cup of noodles. Cup of noodles is actually really popular. And a common pattern that we see for kids is like this baby. A lot of families, you know, they're cooking, there's something on the counter. Toddlers are curious. They reach up, they pull something down. It gets their head, their face, their chest, their upper arm. Very, very common. One of the pictures that I had earlier was also a dip. We see a lot of kids that actually accidentally, like a parent is holding a toddler or a baby, cooking or holding a cup of tea, and they dip their hands in the liquid. Cup of noodles, they get really hot. I said this last year. I think it was a particularly busy day, and there was the cafeteria was crazy, so I went down to Walgreens and I got a cup of noodle soup. I hadn't had one probably in like 15 years and was shocked by how hot it was. And they're also really top heavy. So it's a quick, easy, inexpensive after-school snack. Kids often make them on their own, unsupervised. They may put them on their lap or holding them out of the microwave. They tip over, causing a burn. Contact burns. Contact burns are especially common this time of year. You might see irons, grills, ovens, stovetop covers. They often lead to a deeper injury because they're so hot. This little toddler reaching for a glass fireplace, families, especially with gas fireplaces, families turn them on and have no idea that the outside glass can become very, very hot. Flame burns, we see these a little bit more commonly in older kids, especially teenagers who are participating in more risky behavior, less supervision, maybe doing something like a TikTok flame challenge. But we also see campfires, matches. Flame burns, we're also thinking about inhalation injury. However, this is something that we're thinking about in an enclosed space. So if you have someone who's outside, there's a brief explosion, they're probably fine. But if they're in an enclosed space, like a house fire, then we're more worried about an inhalation injury, which is higher risk of mortality. Mechanical burns. This is something that we don't typically think of as a burn, but this is a friction injury and also something that we see in our clinic and in our emergency room very frequently related to treadmills. These tend to be much deeper injuries. We'll go through in the video that Cindy was showing you, talked about superficial, partial thickness, deep partial thickness. treadmill injuries or burns are often deep partial to full thickness. We often see exposed tendons on the fingers. Chemical burns. A few years ago with the slime, a lot of kids were making slime at home. It seems to be a little bit less popular, but we were seeing a fair number of chemical burns of kids using unsafe ingredients. Big thing I would highlight for this is poison control is a great resource, and we want to flush with copious amounts of water. Tide Pods was another thing that we're seeing. I think both of these definitely with less frequency, but something to think about. Irrigation, neutralizing agents are contraindicated, and poison control. Electrical burns. So one thing that is different for us with pediatric patients is most of our kids that are exposed to electrical burns are household voltages. So as adult providers may be seeing patients who are working on power lines, much higher voltages. Our kids that get an electrical burn are normally related to household voltage. The picture on the top right is a paper clip that was put in an electrical socket. The one below is a child chewing on a wire. So the things that you think about with an electrical injury with adults and the higher voltage, they often get admitted to the hospital. They need cardiac enzymes. They're more at risk for an arrhythmia, but most of our patients, if they come in with a physical cutaneous finding from an electrical current, is they get an EKG. If the EKG is normal, we stop there and we just go with wound management. Most of the ones that we do see are similar to the top picture, bobby pin, paper clip, something small that goes into a socket. The child below, just something to think about is this is someone that we would have plastic surgery see because of arteries around the mouth, high risk for bleeding. So this is also a little bit of a repeat from the video where you guys just watched, but we're thinking about the functions of the skin. This is going back to the basics. Number one is it's going to protect for infection. This is something that we have to think about with acute and long-term management, both in the emergency room, clinic, while patients are admitted. Thermoregulation, temperature regulation, the skin is also going to help prevent from fluid losses, sensory protection, and photoprotection. What's different with kids? Skin is thinner, it's less resistant to heat, there's less subcutaneous fat, and also loses moisture more easily. It's a little blurry. So again, from that video, we talk about first, people often say first, second, and third degree. We will use the terminology of superficial, partial thickness, and full thickness. So a first degree or superficial burn is just the top layer of the skin. A second degree, or a partial thickness, depending on how deep it is, extends down to the dermis, but not fully. First degree burns or superficial are only the top layer of the skin or the dermis. They're pink, they're red, they're painful, they're dry, like a sunburn. They do not blister, and they typically heal in about 3 to 7 days without any scar. They can be painful. That's important to remember. We've all probably, unfortunately, had bad sunburns, that do blister, but even just a superficial can be uncomfortable. These typically heal spontaneously and follow up with the pediatrician. We do not need to see these patients in burn clinic. Also, I'm going to talk about total body surface area when we're trying to assess the degree of a burn. We do not factor in a superficial burn into that measurement. Now, if you are a first responder, you're seeing patients in the emergency room, they may have a lot of red, superficial burn that can evolve over the next 1 to 2 days where some blisters do develop. A second degree or partial thickness burn is the epidermis, the top layer of the skin, and some degree of the dermis, the second layer. These are painful, they blister. Anything that blisters is at least a second degree burn. And most heal in about 2 to 3 weeks without a scar. We're going to go into some more treatment options, but these are both very typical patterns of burns that we see here at Children's National. But these burns are pink, or they're red, they're moist, they're very painful, they're blanching. So if I push on it, the color is going to change and briskly come right back to being a red color. A deeper partial thickness burn extends to the dermis and may look different. There's some characteristics that we notice. It may look more red, may be more beefy red or purple, hyperemic. It can be non-blanching. We can see capillary burst or like little petechia, something that has more of a marbled appearance. These, there's plus or minus pain. I feel like they're always painful. They typically take longer to heal, 3 to 6 weeks, and some may leave scars. A full thickness burn extends through the epidermis and dermis. It can look white, yellow, brown, often requires a skin graft and takes at least 3 to 6 weeks to heal, and we do expect a scar. So a patient comes in with a burn. What are the things that we're first going to think of? The history that we're going to take is going to help us understand the injury, as well as the treatment. Can I take off my mask? Right? Yeah. Oh, sorry. I thought you knew when I used to. Oh, no. I'm just so used to wearing them now. So some of this information may seem, I mean, we always talk about we want to get a full history, but actually it is really helpful. It's really helpful to know what was the substance. If I hear tea, I'm typically thinking that may be a little bit worse than coffee. Typically, I think of tea as water being brought to a hard boil. Sometimes coffee is just in the microwave. Now you can have full thickness burns with all of these substances, but it is helpful. The other thing that's really helpful for us to know is past medical surgical history, as well as immunizations and allergies. The big things we're thinking about with burns, tetanus status, and allergies, especially for sulfa, because some of our medications, such as Silvadene, are sulfa products. I briefly mentioned our TBSA, our total body surface area. It's a really important factor. It helps us understand the patient's response and potentially like the severity of the burn. And what do we need to do? Do we need to bring the patient into the hospital? Can they go home? How sick are we expecting them to get? We have several different ways of measuring this. One of the easiest, quickest references, I think, and I use this all the time, is the rule of palm. So the patient's entire hand, their finger, their palm is about 1% of their total body surface area. So we have apps, we have photos, I'm gonna go over that, but a quick, like, I'm in the middle of a dressing change and I'm thinking how, or a burn debridement, thinking how big it is. I will even sometimes take a kid's hand and not touch the burn, but just hold it as a reference. Anyone can do it, but one hand is 1%. The other thing we have are apps, the Easy TBSA, as well as this is the one on the left is NSW, but the Easy TBSA, Cindy is our creator. It's wonderful. But you can put, It works. Both of these apps, you can put in the patient's age, you can put in their weight, and it's going to help give you an accurate estimation. So both of them are a diagram, and the Easy TBSA goes into actual like physical, like small body parts, whereas this is just a diagram of a body. You can draw over it, calculate it, and it gives you your total body surface area. Facial burns. We do see kids with facial burns. One thing that is important with assessing the total body surface area is thinking about the hair and the scalp. We often see kids that come in with an obvious burn on the forehead, the upper face, and it's missed that the burn extends back into the hairline. So this patient, for example, their TBSA probably doubled with the haircut. So it's always important for us to assess for scalp injury. Now, why does this matter? Our total body surface area matters because it helps us to determine the level of care that is needed. So a patient with less than 5%, there are exceptions to all of this, but typically can go home from the emergency room. 5 to 9%, we're thinking about admission, especially if they're a toddler, they have uveitis symptoms, it's the face. Things that we're thinking about is maybe fevers, not eating well. Anyone with 10% and up is going to be admitted. 10% can go to surgical care, the floor. Greater than 15 is going to go to the ICU for strict fluid resuscitation. For trauma activations, greater than 25% is a trauma activation, and greater than 40% is a trauma set attending. Going back to the basics of functions of the skin prevents against loss of insensible fluids. Burns less than 15% are going to receive maintenance IV fluids. Burns greater than 15 are going to get strict fluid resuscitation. We're going to go into this. But if you guys see them in the emergency room, they're going to get 1.5 maintenance. And then once we get them to the ICU, we're going to start Parkland fluid resuscitation. But it is really important. I's and O's are one of the biggest things for a burn patient. Our goal, and I know we're in, everyone's tight right now, but the goal is to get from the ED to the ICU in less than an hour to start fluid and wound management. So if you have a patient in the emergency room with greater than 15%, we're going to do a rough estimate of our total body surface area. We're going to document the amount of fluid given at the outside hospital or by EMS, and we're going to start lactated ringers at 1.5 maintenance fluids. We're going to try to cover the burn and get them to the ICU in less than 60 minutes. Once they're in the ICU, that's when we're going to try to debride to get a more accurate assessment of the total body surface area. We're going to do Parkland fluid resuscitation, which I'll show you guys, and we're going to start a resuscitation worksheet. Foley is going to go in for strict I's and O's, and we're also going to try to start B's as soon as possible. Parkland helps us determine the fluid requirements of the patient. So it is a calculation using their weight as well as the total body surface area. So we're going to do 4 times their weight in kilograms times their total body surface area. It's important for what we talked about, or I mentioned knowing how much was given pre-arrival or in the emergency room. We're going to take that out because half of this total volume we want to give in the first 8 hours, and then the second half we're going to give over the next 9 to 24 hours. One thing that is important to remember is patients less than 30 kilograms also receive a maintenance IV fluid. So they have patients less than 30, they have their regular D5LR maintenance set on a pump and it's left. We don't touch it, and then the other pump we're going to run our Parkland fluid resuscitation, and the big thing for that is everything is titrated based on urine output. So from the get-go, even if we're not doing Parkland fluids, like a patient's going to go to the floor, we're just waiting on a bed. If you have a patient, we want to know, are they peeing enough because they're losing lots of fluids, and are we appropriately resuscitating them? Parkland is a starting point only. So Foley, urine output, if patients are less than 30 kilograms, our goal is 1 per kilo per hour. Greater than 30, our goal is 0.5 per kilo per hour. They get Q an hour urine output. And then as needed, we're trying to avoid bolusing patients. There are situations where we do, but ideally we're going to titrate fluids up or down as needed by a third. This is a copy of the fluid resuscitation worksheet that is used in the PICU. And nursing, we plug in these numbers, and it helps us with the goal, where we are with our hourly urine output, and then if things need to be adjusted. From there, nursing enters everything in, and it prompts the titration of fluids as needed. Nutrition. So with burn patients, I think of nutrition as an essential medication. Even if it's a burn patient that is going to be going home from the get-go, we want to start telling parents they need high protein, high calories diet to help heal themselves. Their bodies are in a hypermetabolic state. They also need the extra protein and calories to help heal, and they are losing protein and calories from their wounds. So I mentioned patients greater than 10% get admitted. They get started on NG feeds as soon as possible. They also get nutrition. They can PO ad lib on top of that, but we want to give them as much nutrition as possible. If it's you or me or a teenager and they have like an 8% total body surface area burn, you can say, hey, I need you to go home and drink 8 of these protein shakes. A toddler that doesn't feel good, they don't want to eat. We just know, unfortunately, most of them don't end up getting enough nutrition, and so a lot of times they need to be admitted just for nutritional supplementation. We see a fair number of young kids that have scald burns to their head and their face, and securing NGs becomes problematic. This is a picture of a nasal bridle, which I think more frequently is being used outside of our burn patients. It's still predominantly burns, but you may see this other places in the hospital, and it's a way to secure a nasal bridle without taping it to the face. We can put it in at the bedside. It becomes a little difficult, so Ideally, we put it in during like a burn debridement if a patient's getting sedation or pain medication. This is a picture on the top right of how we do it. If you're threading the string behind the septum and you have a magnet that helps pull it out on the other side. The big thing to remember, if you have a patient with a nasal bridle and the NG gets pulled out or if the NG gets clogged, you can open this little trap door even after it's in to take out the NG. So the two things can be done separately. So if you ever, you don't need to cut the nasal bridle out. There's like a little guitar pick that comes with the packaging that's used to open this door. But if you don't have it, I've used tweezers. I've used like any sort of hard piece of plastic. You can probably do it with your fingernail as well. We put them in at the bedside. I recently was asked by the PICU to put one in for a non-burn patient, but the other option is fluoroscopy. Some of the fluoro providers are also now starting to put them in. Burn debridement and dressings. So one of the first things we want to think about is pain control for these patients. They have hypersensitivity to pain, and we want to avoid painful procedures and exposure as much as possible, especially during the initial debridement. So one of the things you can do as their nurses, you can advocate for good pre-medication. We also always want families to pre-medicate before burn clinic or before they do burn care at home. We have several different medications we can use. Oral oxycodone is what we use prior to clinic. Tylenol, Motrin, fentanyl, morphine, ketamine, those are all options in the ER. We also do sometimes take patients to the OR for general anesthesia. And Child Life also has a great role in during procedural support distraction. We have Child Life with us in clinic, tremendously helpful. If you are seeing a patient, if you're discharging from the emergency room or inpatient, please remind them burn care, ideally even if it's Tylenol or Motrin, about 30 to 45 minutes before. And if they are sent home with a prescription for oxycodone, as a reminder, liquid oxycodone is really hard to get in community pharmacies. It's really easy to get the pills. Most community pharmacies do not have liquid oxy on hand. So Walgreens in the lobby, they always have it. And even if their insurance does not cover Walgreens, it's actually very inexpensive oxycodone. So we do often recommend families to pay out of pocket for that if they're having trouble getting it at their local pharmacy. Most patients sent home from the ER are supposed to be sent with a single one-time dose of oxycodone, prescription for a one-time dose. Not the medication, but a prescription. Families can come to clinic a little bit early on their way in, or come to the hospital a little early on their way in, stop at Walgreens, fill their script, take it about 30 minutes before. We do have oxycodone in clinic, but if we need to medicate them there, then they're often waiting. Why do we debride? So this is a picture on the left, pre-debridement, post-debridement. We debride to help with wound healing. We want to make sure our medication can be directly on the wound to help it heal. Something like this, which is a blister that developed and then opened in that little in the medial section of the leg and then the upper portion, germs can get in. Also, this specific, this thinking back to basics of like burn assessment, we're looking at color, thinking a full thickness burn is white. This was a burn that was seen by an outside provider. We don't expect anyone, everyone to be an expert in burn care, but they saw it. They said it's white, it's brown, concerned for a full thickness injury. A wipe, a gentle, one good wipe, all that dead skin, the drainage came off, and underneath we have a nice pink, healthy wound bed. So we talked about who comes to Children's, but also then who gets a trauma burn consult for the emergency room. So anyone that's a full thickness burn, we should see burns that are greater than 5% total body surface area we should see, and we're thinking about possible admission. And then also there are certain locations here as well as mechanisms. The mechanisms are really based on the depth of injury because treadmill, flame, hot oil, those are often deep second to third degree burns. And then special circumstances, concern for NAT or child abuse, patients with fevers, and then a lot of patients come here expecting to be seen by a burn provider. So we will try to see them as well. Thinking about non-accidental trauma, that goes also into our history. We're thinking about what's the story. Does this make sense developmentally? Is that something that seems plausible for a child? What's the distribution? Is it a dip injury where it looks like something was submerged or a hand was put under hot water or contact? Unfortunately, a lot of the ones that we do see are related to bathing, kids being possibly like submerged in hot water. We've talked about these wounds, assessing them, and now what do we do for them? How do we take care of them? These are some of our most frequent burn products that you will see here at Children's. I will tell you, you will often hear our team, myself included, referring to Mepilex AG as Mepilex. When we talk about Mepilex, we always mean AG with silver. So that's something that sometimes happens. We'll say, oh, put Mepilex on it, and people will get out regular Mepilex, which is understandable, that has no medication in it. So Mepilex AG is a silver impregnated form of Mepilex that helps prevent infection and wound healing. Vash is a wound cleanser that we use that helps with debridement. Silvadine or silver sulfadiazine topical burn cream will go in a little bit into this, but that's where I was thinking about sulfa allergies or someone with G6PD where we're not using sulfa products, Aquaphor, and then Xeroform. These are some of our most common. So long-acting dressings versus daily dressings. As much as possible, we will try to get patients into a long-acting dressing. This is one that does not have to be changed every day. It minimizes painful dressing changes. It also can help decrease the length of stay at the hospital. Factors, in addition, we have to think about the depth of injury as well as the location. So if it's something like a diaper area or a face, unfortunately, that's not something we're going to be able to put in a long-acting. That's supposed to stay clean, dry, and intact for ideally like 3 to 5 days. We're also thinking about patient and family preference. So some of our older teenagers, if we say, oh, we're going to get you in a long-acting dressing that's going to stay on for 5 days, but you can't get it wet, I say, no, I'd rather be able to get in the shower and be able to do a topical daily dressing. Things that we're thinking about for the daily dressing. So anything that's a full thickness injury typically needs a daily dressing, something with dry eschar that the long-actings won't penetrate. If we're concerned about infection, we're going to do a daily dressing change so we can be getting the wound clean. Also, our daily creams tend to be stronger. And then, as I mentioned, the diaper and the facial area. So Mepilex AG, this is our most frequent, most used dressing, especially in the initial management of burn, of a partial thickness burn. So if you're in the ER, this is what you're going to see. We use it, it's a silver impregnated dressing. It's soft, it's silicone, it is absorptive. It will collect the drainage that's coming out of the burn. That drainage actually helps to activate the silver that's impregnated in the dressing to help keep it clean and protected. This stays on 5 to 7 days is what the manufacturer recommends, typically after the first dressing. So if you see someone in the emergency room, we typically have them come back about 2 to 3 days after their first debridement and dressing change. The wound is the most exudative during that time. Kids are active, dressings may be falling off, but it can medically stay on for 5 to 7 days. So it's really important. A lot of times families don't understand that this has medication in it and call in a panic and say, we need to be seen tomorrow, we have this bandage on, but this has medicine in it. It is treating their burn and it can stay on for 5 to 7 days. We recommend removing, there's a plastic backing on the sticky side, sticking it on. We always do recommend wrapping. You could put the Tubifast shirt on top of it, which is great, but that is not enough to keep it from falling off. So often we'll secure it with Curlex or cling and then put like a Tubifast shirt on the outside. Another long-acting dressing that we use, this is more frequently used just by us in clinic, that's a little bit stronger and a little bit more difficult to apply. So that's why we try to simplify things and keep this out of the emergency room, is called Acticoat. It is a sustained 3 or 7 day antimicrobial dressing. It has more coverage against broad spectrum including MRSA, Pseudomonas, and it is The picture here is the product just laying directly on the hand. It's like a thin mesh that's gray, black, brown in appearance. What we would do is we would cut it and then wrap it around the fingers, but we apply it with another product called Mepilex that makes it more easy to remove. One of the things that I tell families, and if you guys are taking care of these patients to know, the brown, black, gray color of the medicated bandage, when it mixes with the exudate of the burn, can often turn the drainage on the outer dressings like a brown, black color. And it doesn't mean it's infected, it's just the staining from the silver on the dressing. Daily dressings, Silvadene or silver sulfadiazine and sulfamyelin are often used on deep partial to full thickness burns. If we're concerned about a wound infection, if we have dry eschar that needs penetration, these are the creams that we typically go to. They're going to give you better antimicrobial coverage as well as eschar penetration. They're daily dressings, contraindications, G6PD, sulfa allergy. So when I talk about a full thickness burn or eschar, this burn here on the edges, it's nice and pink and it's healthy. That center where it's brown, white, it's going to feel dry, it's going to feel leathery. If I put something like the Mepilex on top of that, it's going to sit on it, it's going to look nice, but it's not going to do anything to try to penetrate through that thick, leathery eschar. So that is an example of something that we would do a daily dressing. Same with this hand. Now, with this hand, this is the same patient in the emergency room, a toddler, a recent patient who touched a glass fireplace cover. The white on this one on the left, that is a full thickness burn. It's white, it's dry, it's leathery. That we had to put in a topical daily dressing. Whereas the other hand is pink, it's moist, that we did in the long acting. So sometimes that's a little confusing for families, but even just simplifying and taking a component of dressing care, a wound care out of it for families makes a big difference. So sometimes we will do combination dressings and we'll say, keep this one clean and dry, this one you're going to change every day. Xeroform is another example of daily dressings. It is often used for partial thickness burns on buttocks, face, scalp. It is a Vaseline gauze that is also impregnated with bismuth. It helps keep the wound protected and hydrated, and it is bacteriostatic. It keeps the germs out of the wound. We still need a nice clean wound before we put it on. Sometimes we'll also use it with bacitracin or another ointment, but this is really popular or common for us to use for toddlers, babies in the diaper area. We open it up. I sometimes like to do like a double layer, and you can put it directly on the wound. You can also line the diaper on it, so there's something that's really sitting on it and providing more moisture. Bacitracin is a topical antibiotic ointment, and we change it anywhere from 1 to 3 times a day. Any daily dressing change, the wound needs to be getting cleaned. That is something we often have families come in and say, I was told not to clean it. If they're changing a dressing, we want it cleaned with soap and water before the new bandage is put on. Facial burns are really, really tough. They are hard because you can see the burn. It's generally exposed all the time. It's upsetting to families. There's a lot of drainage. There's a lot of swelling. They heal very, very nicely. I'll show you guys some pictures, but the big thing from the beginning is we want to keep it clean, we want to keep it moisturized, and we want to protect it from the sun. So from the get-go, if a patient comes into the emergency room or is admitted, this is something that families are going to have to do at home until it's healed. So we want to start trying to teach them and at least expose them to the idea of burn care from the beginning. Vash is that blue bottle of wound cleanser that I showed a picture of. Here, I have it here. So we use it a lot on facial burns. It really helps clean and debride by soaking it. It's not so much how much you use, but if you put it on and leave it on for like 5-10 minutes, it really helps soften up exudate, dried exudate, and help debride it. So often we'll take like a single layer of a 4x4 put Vash on it, put it on the face, and a Telfa, wrap it up, leave them be for like 5-10 minutes, then you go to take it off, and it helps pull off all the old gunk and goop. It is really helpful for us, but it's one thing to remember. It's not so much the amount, it's actually soaking the burn. This is a picture of the face 3 days after injury and 11 days after injury. This one is also 11 days after injury. There's no magical 11-day number. This is the girl a day of injury in the emergency room, 11 days later in clinic. I know it's hard to see, you can't see their eyes, but eyes get very swollen. Everything gets really, really swollen. It's really red and pink and it's exudative, but they do heal nicely. And I never want to promise a family that there's going to be no scar. I want to set realistic expectations, but the face is super tough to see, but does heal very, very well. Full thickness burns, they go through all the layers. They may be white, yellow, brown, dry, thick. This is 3 to 6 weeks to heal. We often expect a scar, and they may require a skin graft. So who gets grafted? It's not a simple answer, and there's a lot of factors that go into it. One of the things we have to think about is how the child is doing. Someone has a really small, full thickness burn. Its dressings are fine, not causing a lot of problems. Family doesn't want to undergo surgery to excise it and create a new wound for a skin graft. That's fine, and oftentimes we'll let them heal on their own. But if it's a bigger injury, it's going to take 6 weeks. 6 weeks of daily dressings. It can even be longer than 6 weeks. Each one of those dressings is painful. The patient may be extremely hypermetabolic. It's too much on their body. And then we also think about scar, location of the scar. A patient with a full thickness burn, regardless if we operate or don't, is going to have a scar. So the question is, what kind of scar are we going to give them, and can we give them a more functional and better cosmetic outcome? Unfortunately, a lot of our burns are what we call mixed, so like a mixed injury. So it's like a partial to full thickness. And there's a question of, do we operate, do we not operate, what's going to heal on its own, what's going to not. It often takes like a good week, unless it's an obvious full thickness flame burn or contact burn. I'll show you some pictures. We often let some time pass to let the body declare itself. And I'll show you guys some more pictures. But types of grafting, an autograft is taking skin from your own body and transferring it to cover the wound. An allograft is a donor, or typically a cadaver skin, so it's skin taken from the same species, but a different person. And then xenograft is taken from a different species, which is typically pig or porcine skin. Allograft and xenograft are both considered skin grafts, but are temporary. Those are not permanent, whereas an autograft, taking a patient's own skin to cover their wound, the goal is that the graft is going to take and it's going to be permanent. Now we also have full versus partial thickness, as well as mesh versus sheet grafts, and these go into some of the types of grafts and the surgical procedure. So most of our patients that get a skin graft get a meshed autograft. So a piece of their skin is taken from another part of their body, typically their thigh. It is the top layers of skin. It can often be very painful. It is pushed through this device that helps mesh it, and so you can take a smaller piece of skin and get a larger area to cover by meshing it. And then those little holes fill in. So a full thickness burn that can't heal from the bottom up can heal from the outside in, but the same way that these little meshed holes will heal, they will fill in on their own. Most of our patients that get a skin graft do get admitted post-operatively. Some of our bigger burns are here, admitted, get serial trips to the OR or skin grafting, but a lot of our smaller burns, outpatients that get a skin graft come in. Sometimes they go home, same-day surgery, but oftentimes they'll be admitted post-operatively. They may have a wound back on their graft. The post-op graft, that skin, it is typically stapled down or sutured down, and then a very secure dressing is put on top, because what we want to try to do is minimize any friction or irritation or something that may cause the graft to not stick, to not take, graft loss. So this is an example of a full thickness hand burn. This is an 8-year-old. He was seen at an outside hospital and then urgent care. It's from a treadmill, so it's pretty uniform in that it is full thickness pretty much everywhere. Some of the areas in the fingers and the borders, those are partial thickness and did heal on their own. But this is a kit from the very beginning. It's white, it's brown, it's yellow. You think about it, how long this is going to take to heal. And then we also worry that if this heals on its own from the outside in, he could have scarring that could pull the hand, pull the fingers, pull the hand, and limit use and function. So he was initially treated with Silvanine, and then he was taken to the operating room for a skin graft. This is a picture of a skin graft on post-op day 3. So I mentioned he was put in a wound vac. We often try to get them in a home wound vac so they can go home from the hospital. So I'll show you a picture of his donor site, but right by donor site, skin on top of the hand. It is meshed, but it's very small. Like we have different ratios that the surgeons use for how much we need to spread that skin. There are little stitches around the edges, but those are all absorbable. The wound vac was on. He came back to the hospital 3 days later, back to the operating room for the first dressing takedown. If you have a teenager or it's like a really compliant patient, we can try to do the first dressing takedown in clinic, but we really want patients to be still. Like it's very fragile, so the last thing we want is like a toddler moving their hand or pulling or anything that may cause additional injury. So that's 3 days. Follow-ups after that are back in clinic, 17 and day 29. Doesn't look that brown, it's not the best picture, but that is fully, even at day 17, that is fully epithelialized. So it is new skin, the wound is closed. You can see across his fingers where there were some deeper areas of injury that were not grafted, that you can already see scar bands starting to form. And so it's really important from the beginning, and I'll touch on this, that physical and occupational therapy for us are huge. They're in clinic, they see our patients in clinic as well as in the hospital. They also follow our patients in their own clinic for long-term scar assessments for function, because this is a hand we want to keep moving and we want to make sure that these scars don't limit function. So in the very beginning after a skin graft, we may want to protect the wound and the graft as much as possible and say, you know, no bending of a leg, limit hand movement, non-weight bearing, if it's something like a foot or an ankle, because we don't want to shear. Other than that, we want patients up, moving, ambulating as much as possible. So the donor site, the skin was taken, this is from his right upper lateral thigh. And again, we have day 3, day 8, day 17. Day 8, except for that one little area that's bleeding, that's healed. So it healed in about a week. Our goal is to have them healed within 2 weeks. Sometimes, unfortunately, they take longer. The donor sites are often the most problematic and the thing that the patients complain about. They are like a really bad road rash. Imagine who's like on a skateboard going down a hill, fell off, and just got a huge abrasion on his thigh. They bleed a lot. So if you are taking care of a patient in the PACU or who is admitted to surgical care post-op, you may see some strike through, some bleeding around that. It's okay. It's not unexpected. We often will change their dressings before they go home on post-op day 1, but it is very painful. Typically, the graft donor sites, we do manage with Mepilex AG, a long-acting bandage that they don't have to change at home. So post-operative care, if you have a patient admitted or a patient in the PACU after a skin graft, things that you're thinking about: pain control, for all of our burns, pain control. Because it is the top layer of skin where they excise the donor and also excising of the full thickness burn, there can be a lot of blood loss. So sometimes patients are transfused in the OR, but we're thinking about symptomatic anemia. So if you notice the patient's really tachycardic and it's not related to pain control, that's another consideration. Dressings, activity. So maybe we have some restrictions for them, or maybe we want them up and moving as soon as possible. Home care. Case management helps us with our home vacs if we're sending a patient home in a vac, as well as education for families. So I was saying earlier that a lot of our burns, unfortunately, are like a mixed depth injury. The hand that I showed you was a clear, essentially the entire thing was a full thickness injury. Same with the palm that touched the fireplace cover, or if you have something like an iron where it's nice and uniform, you're going to have everything is pretty much the same as a full or deep partial thickness. Most of our patients, though, are something like a scald burn or have mixed depth. So this is an example of The areas that are more pink healed on their own, and then the center of the upper arm and the forearm, those are areas that underwent a skin graft, and so that's why there's different pigmentation or color. Same with this patient as well. So the paler areas all healed on their own. The left shoulder and the left upper arm, which you can still see a little bit of the meshed appearance with skin graft. This is a patient that we saw in clinic that was sent to the emergency room. And sorry, I should have warned you guys. These are just some pictures of a full thickness injury. They had been using a topical ointment that was like a blue-green. We couldn't touch it. We couldn't clean it in clinic, so we sent her to the ER. She got sedated. We tried to get that off. Again, we saw that wound, thought it's probably full thickness, but it's also really hard to tell because we can't actually see the wound bed. That was after a sedated dressing change or sedated debridement in the ER, and we took her, posted her for surgery within the next 2 days. She was able to go home, but we did bring her back for a skin graft. Again, it's very fragile. It's meshed over this area. The knee, it's a high movement, high tension area, so she was probably in a vac and maybe a knee immobilizer for the first 2 days. And then this is her first clinic dressing change, and about 3 weeks later. I mentioned this a little bit, role of physical and occupational therapy. They really are essential to us. They see patients both in the hospital as well as in clinic. Range of motion exercises, splinting to try to prevent contracture formation, as well as they help see our patients for compression garments, which is this little boy on the right, to help try to minimize scarring, as well as helping with itching and sensitivity. We often put patients in compression garments after they've healed, and physical and occupational therapy does this. This is a little doll we have that has an example of what like a compression garment might look like. Social work. Any burn patient less than 2 years old or anyone that there's social concerns, social work should be seeing. So if you're in the ER and you have a toddler burn, social work is supposed to be seeing them and doing a screen and assessing family for any needs. Clinic, we have a burn psychologist. The last video that Cindy had showed you, it had gone from Liz Webble, one of our providers, to Carrie Tully. She is a child psychologist that is with us in burn clinic, also sees some of our patients inpatient. She sees them for support during their initial visits, but also sees them for separate support and appointments independently, because this can be so disruptive and traumatic for the patient as well as the entire family. Long term, we do further scar management, as well as we do it as well as our plastic surgeons. We do laser, scar excisions, steroid injections. We also see patients for telemedicine. I'm not going to, Cindy showed this to you. I can't highlight this enough to you guys. It was really, really good. And I would encourage you to please have families, let parents know that this is a resource for the after the burn videos. We'll often put them in as Get Well Network videos, and I don't know how much they're watched. The burn discharge instructions as well has a code for families to be directed to the videos. I know some of these educational videos are really generic and not that specific, but one of the ones that's so great is even, let's see, where is it? It's the at-home burn care, and it walks through the steps for families if they need to do dressing. So if you're seeing them in the emergency room or clinic, or they're admitted, it's overwhelming. There's a lot of information thrown at them at once, and suddenly they're going home and they're doing burn care. They can watch these videos. It walks through the steps. So we would really encourage you to highlight to the families to know that this is a resource. It's on YouTube. Anyone can watch it. We also it goes over nutrition, pain control, sun protection. That's a factor for scarring. I'm going to briefly talk about safety. But this is, yes, talks about hospital stays. So what does a healed burn look like? Everyone wants to know what a healed burn looks like. Families want to know from the beginning, is it going to leave a scar? Hopefully no, but it's important to set expectations that are realistic from the beginning, in that even burns that don't leave a permanent scar may take weeks to months for the color to even out. So this is an epithelialized or a healed burn. It is normal for it to be pink. It gets more blood flow, it's more vascular. with things like massage, a hot bath, a temper tantrum, or like crying, you may notice increased blood flow and it looks more red, and then it may even out. And then there's also a factor of the pigmentation or the skin color. So as the redness or the pink fades, often this will look paler than the rest of the skin, and that is because it is hypopigmented. The color has not returned. The most important thing a family can do at home to try to prevent it coming back nice and evenly is good sun protection, time and sun protection. So this is normal. If we have especially an inpatient burn, especially the face, over the first few days, you may notice it goes from wet, draining, to being pink and dry. Pink and dry is great. So I'm very happy with how this looks on the right, but I also understand that that doesn't look the same. We are never going to take down a dressing and have it look like 100% like the rest of the skin, even something that's not going to leave a mark long term. So the basics of scar management: moisture, massage, no sun. Liz's video that Cindy was showing you says it's itchy. It's often very itchy, it's dry, it's fragile. So scar massage with a gentle moisturizer. It doesn't need to be anything special. Aquaphor, Eucerin, Aveeno. The act of applying that moisturizer and then rubbing it in helps strengthen the skin, it helps desensitize it, breaks down scar tissue, and then minimizing sun exposure helps prevent secondary damage and discoloration. These are examples of moisturizers. Aquaphor is what we have in the hospital, what we have in clinics, so we frequently use that, but any of these would be appropriate moisturizers. Sun protection. We really encourage use of, once wounds have healed, use of a sunscreen that is mineral-based or has zinc oxide in it, as well as protective clothing like a hat, sun shirt, any sort of protective clothing to keep the area just covered, because it can cause long-term discoloration, but the sun can also impact the texture of the skin and the flexibility of it. A few years ago, we haven't done this last few years, but we used to sell burn shirts. And it was kind of like a buy one, donate one. So we would sell one, and for every one that people bought, we would donate to a patient in burn clinic. So hopefully we'll be back maybe next year. Advanced scar management. So anything that takes greater than 3 weeks to heal is more at risk for a scar. Mentioned we do compression garments, silicones, steroid injection, laser therapy. One of the things about burn scars is they tend to peak or be worse around 4 to 6 months, and then will gradually soften and get better, not resolve, but often get better. And things that are risk factors for something like a hypertrophic scar would be greater than 3 weeks to heal, high friction areas, young and old age, as well as a family history of keloids or scarring. And that is it. This is one of our patients who had signed a consent. This is one of her burn shirts that she was gifted in clinic, had burns on her chest and abdomen and shoulder. So just protective clothing, especially now, I feel like so many kids just wear rash guards or sun shirts. It's a great way to keep the wound protected. Anyone have any questions?